All right, good afternoon. Today we're going to talk about newborn transition and adaptation. This is chapter 23 in our book, and these are our objectives. And we will jump right into it. All right, right after the baby is born, we have a transition period. And the first part of the transition period is called the first period of reactivity. The baby's awake, okay, they're pretty alert. And remember what's happening once the cord gets clamped and cut, the baby starts having to, use its own heart, transfer to adult circulation, and it doesn't happen immediately. So the heart rate is 160 to 180. Baby's probably going to startle a lot, tremor. Sometimes they pass meconium right after birth. It's not unusual for the baby to have irregular respirations, crackles, grunting, retractions, any of that kind of stuff. If they may be tachypnic, even up to like 80 breaths per minute. And what is a good activity for the first period of reactivity? Breastfeeding. We want to breastfeed as soon as we can. And to do this, now what we're advocating is that that baby should go skin to skin, naked skin to naked skin, immediately with mom. Now, some moms don't want their babies on their bellies until they've been wiped off. But the best thing for the baby is to go immediately to mom's chest and for us to dry and do any resuscitation on that baby on mom's chest. Mom will help keep the baby warm and ideally help the baby, stabilize their temperature and their respirations. So skin to skin is awesome. That first period of reactivity is the best and most important time for breastfeeding. We need to get that baby to the breast in that first period of reactivity. Okay, second period of, then we have a period of decreased responsiveness. So after that first 30 minutes, baby is going to be sleepy, and it lasts a couple of hours, anywhere from 60 to 100 minutes. Baby may have rapid respirations. They're going to be more shallow, but they won't be unlabored. And they could be up to 60 beats. They start to slow down their breathing as they transition. Acrocyanosis. What is acrocyanosis? It's the blue hands and feet as that circulation gets established, and that's normal. And so it is a sleep phase, totally. Okay. Then we have the period that, okay, I guess it didn't turn. Okay, then we have the second period of reactivity. That's our next piece here. And 2 hours after birth, it can be a very short time. So it may only last 10 minutes to several hours. And so again, to hit that second period of reactivity, it's good to keep that baby on mom's chest at all times. It tends to be a very hyper alert state. I'll show you the picture. Here's a baby who's in their second phase of period of reactivity. And very responsive. Again, this would be the best time to get them on the breast again. We want to breastfeed early and often throughout their hospital stay. And again, you can read what we see. They do have increased mucus secretion, so they may need to have some suctioning done. But again, it's less of a problem if they're skin to skin. And then they will have bowel sounds, and they often pass meconium. You may notice a brief change in skin color called the Harlequin sign, and we will talk about that in a little bit. And you may see some tachycardia and tachypnea, but they will be transient, so it will come and go with those babies. Okay, so second period of reactivity, again, same as with the first one. You want to have the baby skin to skin, bonding, breastfeeding. Those are the main goals. All right, which time frame is most appropriate for the nurse to initiate breastfeeding? So first period of reactivity, first period of inactivity, second period of inactivity, second period of reactivity, and the key word there is to initiate or to start breastfeeding, and that would be obviously the first period of reactivity or right away. Okay, so keeping in mind what we know about fetal lung development from way in the very first part of the class, 20 to 24 weeks, and now it's probably more like 20 to 22 to 23 weeks gestation, alveolar ducts are just starting to appear. So the fetus has breathing movements that are seen at 11 weeks, but technically that fetus is too young to survive because they don't have enough ducts. The lungs are just not formed. 24 to 28 weeks, the alveoli are there. They're not matured though. They could support gas exchange. There may be some surfactant, but it's not enough. So that baby could live outside the womb. It would have to be ventilated. It's not enough surfactant though to keep those open. Okay, 28 to 32 weeks, we have our active surfactant production. Things are getting better, and towards the end of that, they probably don't need as much support, but we haven't reached our peak surfactant production, which doesn't happen until 35 weeks. So after 35 weeks, a baby could be born and not need to be on a ventilator. But before that, we are looking at ventilation. So just keeping that in mind. And what is surfactant? I know we've talked about this. Lecithin, sphingomyelin, they are the phospholipids that basically keep those alveoli opened all the time. It's the smooth, slippery stuff so that they don't kind of fall together like a wet balloon. So lecithin, sphingomyelin, at lung maturity, there would be 2 parts of lecithin to 1 part of sphingomyelin, okay? So that's called the LS ratio. And this is what we used to do quite a bit of if we were worried about needing to deliver a baby early, but wanting that lung to be more mature. We would do an amniocentesis, take out some of the amniotic fluid, and check it for the LS ratio, lecithin to sphingomyelin. And a 2 to 1 means that we would be able to deliver the baby. Now, and we know that surfactant increases lung compliance, right? So nowadays we have a synthetic surfactant, so that it really, the LS ratio is kind of going by the wayside because we can go ahead and intubate the baby and put surfactant down into the lungs, and it helps a lot, and we vent babies much less than we used to. Okay. All right. This is a good review video for you, just on baby circulation, kind of right after birth, what is actually happening with that heart and lungs. Okay. Now, respiratory adaptations. What happens? We have different, and look at the keyword again, initiation of breathing. It's the start of breathing. There are different factors that actually go in to making that baby breathe for the first time. And the first one, chemical factors. Babies have asphyxia normally from the vaginal birth. They have that squeeze that's happening, and also with the squeeze with the contractions, and also the squeeze through the birth canal. So they're going to have a little asphyxia anyway. When we clamp the cord, obviously, that stimulates chemoreceptors in the aorta and the carotid. And so those chemical factors will trigger respiration, trigger the effort of respiration. And I spoke out of turn. The vaginal squeeze, which pushes the fluid out of the lungs, is the mechanical factor, because baby's been breathing in and out of fluid to mature the surfactant, mature the lungs. And so it's basically the baby after 11 weeks is just practicing their breathing movements. That breathing in of amniotic fluid helps develop those alveoli. Okay, but we got to get that out before the first breath. And so the baby gets a vaginal squeeze if they go through a vaginal delivery, pushes out that fluid so that baby can go ahead and when they take a breath, get the air into their lungs. Thermal factors. What happens when you jump into a cold pool or you walk outside and it's freezing out? You take that deep breath, okay? That cooler environment stimulates the baby to take a deep breath. And then sensory factors. Baby's been in this kind of muffled area. They can hear mom's heart rate, and it's dark generally. But if they're born and it's much louder and bright lights, and they're getting skin stimulation, which they've really never gotten before when they get dried. All of those factors come together to stimulate the baby to take that first breath. And remember, that first breath is the most important. We have to get that baby to start those respirations. And it's the biggest breath they ever take because it opens up their lungs. Now, not all babies have a smooth transition with this. If you don't have enough surfactant, okay, sometimes we do C-sections and they don't get a vaginal squeeze, and so their lungs may be wet. They may need more suctioning, okay. Some of the things that hamper respiratory transition would be prematurity, polyhydramnios, which is too much amniotic fluid. If there is a physical defect, like a diaphragmatic hernia, which we'll talk about later, and cesarean sections, all kind of hamper that transition to take that first huge, big old breath. Okay, now what we see, and these are your blanks, and these are the answers that are on your PowerPoint. Periodic breathing. So it's normal for babies to not have regular respirations. They may have a 5 to 15 second period where they just take a pause and then they start breathing regularly again. There's no color or heart rate change. This is periodic breathing, as opposed to apnea, which is about 20 seconds. They are obligatory nose breathers. So what would that mean? If we were going to put oxygen, like blow oxygen on their face, where would we put that? We would put that by the nose, right? And then they breathe normal is, of course, you know this, 30 to 60 breaths per minute. We always count for 1 full minute because of that periodic breathing. We want to know exactly what it is. So you just keep counting every breath for the whole minute. And we know, though, that that 30 to 60 is normal, but for the first couple of hours, we may see some tachypnea and may be breathing faster. Okay. Periodic breathing usually happens more often during REM sleep. Okay, that more active sleep part of the sleep cycle. All right, so how do we know if a baby is transitioning well or if they're having some respiratory distress? Okay, so increased respiratory rate. All right, so they're breathing faster even after that first couple of hours when it's normal that they should have slowed down. If they're grunting, which grunting sounds kind of when they breathe, usually on expiration. Nasal flaring, so their nares flare open, trying to get more oxygen in. And then retractions, intercostal, subcostal retractions. So some of the color changes that we see. Acrocyanosis. Now, we talked about acrocyanosis as being normal, right? Well, that is for the first 12 to 24 hours. But if you see acrocyanosis hanging on longer than those first 24 hours, we need to kind of investigate why that's happening. If they have central cyanosis, so their trunk, or the best place to look for cyanosis is the mucous membranes. If they're kind of bluish, that is a sign. And then circumorocyanosis. Circumorocyanosis, people get this easily confused with acrocyanosis. Circumorocyanosis, think of circling the mouth. It's basically blueness around the mouth. Okay. When we see circumorocyanosis, we worry about cardiac disease. Now, what can happen if we may see a baby who has a really blue face? We have to rule out breathing, and the way we do that is we have to rule out bruising. And the way we do this is to look at the mucous membranes and see if they're nice and pink. If they're blue or purple, then we know we have true circumorocyanosis. Now, when we talk about the retractions, we have intercostal retractions and we have subcostal retractions. Okay, so if we see a baby basically is working really hard to breathe, that they're pulling in so much that we can see the baby's ribs really well. This would be circumorocyanosis. The baby's lips are kind of pale. They're not pink, pink, pink. So this would be something that you want to investigate. Okay, and then this is our acrocyanosis. Acro is outside cyanosis, and we have purple hands and feet. Okay. All right, so what do we do to support that respiratory adaptation when babies are born? We're going to clear that mouth first. We want to not have the baby sucking any fluid that's in the mouth into their lungs. Clear the nose then. And a lot of times the mouth is suctioned at the perineum with just using a bulb syringe. If there's meconium, they may use a DeLee suction. And then after the baby's out, make sure we suction the nose. We don't want to be sticking a lot of stuff in there though, because we don't want those nasal passages to become swollen and then kind of make the baby become a mouth breather. And then we stimulate. We do not have to get rough with the baby, but we know one of the most important things to do with the baby when they first come out is to get them dry, because thermoregulation is really important too. And so that will also help support respiratory adaptation. So we stimulate the baby, rubbing gently, drying the baby, and then hopefully the baby will cry, because a good healthy cry helps to push any residual fluid out and means the baby is taking that biggest breath that they ever needed to take. And then again, we can give oxygen. We can just blow, we call it blow by oxygen, just, you know, close cupping that oxygen cord right by the nose. We may put a mask on the baby if they're really not doing great. And then if the heart rate is below 100, we will actually bag, you know, use a bag and mask and bag the baby and push some oxygen into their lungs. Now, this is a video showing you how to use a bulb syringe. Pediatricians don't really want parents to be messing with the bulb syringe because it's a one-time use deal. You cannot clean it effectively. And again, it can really make those nasal passages swollen. So we don't want to mess with that. Okay. Now we've talked about this in great detail during OB orientation. So we're just going to run through it. The cheesy white stuff that we see right after birth is called the vernix caseosa. And babies may be really red at birth, but it will fade. They may be blotchy depending upon how mature they are. If a baby's post dates, their skin is going to look very different. And again, we talked about the acrocyanosis, and then the fine hair that's noted, lanugo. And the younger a baby is, the more vernix and the more lanugo the baby will have. And you can tell this is a preterm baby. They don't have any fat underneath the skin. Now, I don't expect you to memorize fetal circulation in great detail, but you do need to know about these 3 shunts. These 3 shunts help the fetus as they're developing in mom's uterus. They help shunt the blood away from the lungs, because if the baby's in utero, they're getting their oxygen through mom's, the umbilical cord and the placenta. So they don't need to use their lungs. So these 3 shunts basically shunt the blood away from the organs that don't need it as much. And so that is why these 3 shunts are what make up fetal circulation. Okay, so they minimize the amount of blood that goes to the lungs and the liver. So the venous ductus venosus is the first one. Bypasses hepatic circulation into the inferior vena cava. Foramen ovale shunts the blood from the right atria, which, remember, the right atria in utero has a higher pressure, to the left atria. And then the ductus arteriosus shunts the blood from the pulmonary artery to the aorta. So bypassing the lungs, bypassing the organs that don't need as much blood in utero. And you can see this makes up the fetal circulation. So we're bypassing those, and we do not need that until until baby is out of the uterus. Once they're separated from the placenta, which is giving them everything that they need, then we need to start them on normal adult circulation. So what happens to change all of these ducts into adult circulation? So once that cord is clamped, basically, and baby is kind of flying solo without mom's help, the pulmonary vascular resistance decreases dramatically. And so we have blood that is increasing, is flowing to the lungs just because that resistance has decreased. We have an increased systemic pressure, and that causes the closure of the ductus venosus. And then because of that increased blood flow into the lungs from the left side, it increases the pressure in the left atrium and it closes the foramen ovale. And then as we have more and more pulmonary circulation, then the ductus arteriosus will close. And when these ducts close, they can, especially the foramen ovale and ductus arteriosus, they just have like, it's a light membrane. The flaps on these are very thin. And then as the baby matures into infancy, that membrane that's very thin will get thicker and thicker, and it patches over and it closes for good. But both the foramen ovale and the ductus arteriosus can kind of go back and forth in that first 24 to 48, maybe even to 72 hours, depending upon what's going on with that baby. So sometimes they will stay patent, and then that's when we start hearing murmurs, and we need to watch the baby pretty darn closely. So decreased pulmonary vascular resistance opens up the lungs, closing the ductus venosus because we have increased systemic pressure, perfuses the liver. Foramen ovale, which closes in the first 2 hours, and the ductus arteriosus takes 15 to 24 hours to close. That all is happening when we have the clamping of the cord and the first breath. So those two events, clamping of the cord and the first breath, are monumental events because they are starting the process of fetal to adult circulation. So fetal to adult circulation is such a miraculous process. And a major factor in all of this is that increase in arterial O2 content, because we haven't had that before as much. And so when baby starts taking that first breath, increases the systemic pressure, and we know that we have increased O2 in the arteries. Okay. All right, so that's as deep as you need to get with fetal circulation. We could go a whole lot deeper, but we're not going to. Okay, and again, pictures. And there was a video also. So what should all of this be? Heart rate. Again, we take an apical pulse between what numbers do we want for a rate? Between 100 and 160. If a full-term baby is in a deep sleep, it may be less than 100, but when they're first born, we don't like that, and we may start bagging that baby. So murmurs, again, are common because those fetal shunts have such delicate membranes, and they're kind of opening, maybe leaking a little bit at first. The ductus arteriosus is the most common one, and so most of the time they're transient, but if those murmurs don't go away, we need to really follow that child. There may be a hole somewhere. So let's see, blood pressure values. We do not do blood pressure routinely right away unless we suspect that there are problems, but we do check a mean arterial pressure before babies go home. So, okay. All right, transition to extrauterine life and conversion from fetal to adult circulation begins when When does it happen? And the answer would be D, with the first breath. Okay, hepatic adaptations. Fetal circulation is less efficient at oxygen exchange, obviously, because we're bypassing the lungs. So what do we need? We need more RBCs. And so RBCs, hematocrit, and hemoglobin, we have more of them. And what do we know about fetal hemoglobin that makes it special? Fetal hemoglobin carries a lot more O2 to keep the baby oxygenated during utero. Okay, so we may see a hemoglobin at birth for the baby at 14 to 24, and it will go down from 12 to 20 in the first couple of weeks. Okay, so we are seeing a greater, higher rate of hemolysis in babies who are born. Those red blood cells, the fetus, do not have as long a life. Okay, much shorter red cell lifespan, and so that blood cell. So we do see that those red blood cells are being destroyed or dying at a faster rate also. Okay. Okay, so 80% of newborns' blood at birth has that special, awesome fetal hemoglobin. And because they die more quickly, babies in the beginning may have a decrease in those red blood cells, and so they have a lower iron. Okay. Usually babies, especially babies, we don't notice it as much because babies from birth to 4 months use mom's iron stores if mom had had good nutrition during pregnancy. And so, but around 5 months of age, we see a drop, and babies who are breastfeeding need to probably have some iron, take some extra iron. Okay, leukocytosis, where we have an elevated white blood cell count, is normal. It's basically, it's not a sign of infection necessarily. It's just that we have a lot of stress for birth, and we know white blood cells can increase. Okay. All right, so coagulation. The clotting factors, all of them, 2, 7, 8, 9, 10, all of them are basically activated by vitamin K. So you have to have vitamin K to stimulate, activate the clotting factors, okay? What do you have to produce vitamin K? You have to have bacteria in the gut, okay? So babies, when they're first born, have a sterile gut. So they don't have any vitamin K, and that's why we have to supplement that. We give babies at birth a vitamin K aquamaphytin shot. And at Sanford, we do it in the right thigh, because they have no flora in the intestine. So until they start eating, they won't have that normal flora that creates vitamin K. And so if they don't have vitamin K, the clotting factors will not be activated. And if baby bleeds, they could bleed to death. So that is why we have to give a supplement vitamin K in the beginning. It helps immediate bleeding problems. Now, if mom is breastfeeding, the baby starts producing bacteria almost immediately. With bottle feeding, the bacteria takes a while. The normal flora takes a while to develop. Okay, so breastfeeding is better for that also. Very important that you know what we're talking about with this. With this slide, you need to know vitamin K activates clotting factors. To get vitamin K, you have to have normal flora in the gut. At birth, the gut is sterile, so that's why we give vitamin K shots to babies. And so it's really important to be able to tell parents that, because some parents want to refuse. They think it's not natural to actually be giving shots, and why do they need vitamin K, and babies don't bleed to death. But you don't want to have that baby who has von Willebrand's disease and does have a huge brain bleed that we can't stop. So, okay, so we had breathing, heart rate. Those are the big transition things. The third most critical transition piece is thermal stability. All right. What happens? Why do babies have such a hard time in the beginning to regulate their temperature? They don't have subcutaneous fat. They have a large body surface area compared to their weight. They have blood. Since they don't have a lot of subcutaneous fat, the blood vessels are near the skin, and so they cool more quickly. The blood cools more quickly. And how do babies try to keep warm? They try to keep warm because they can't shiver. They are in a flexion state, okay? And they have brown fat that they burn, but they have a limited amount of brown fat. So if they are using up their brown fat and they use it all up, they will start burning glucose. And so that's a problem, but I'm getting ahead of myself. So because of the newborn characteristics of decreased subcutaneous fat and a large body surface area and blood vessels that are up close to the skin and the flexion that may or may not be enough, they lose heat 4 times faster than adults, and they lose it from their head the fastest of all. Okay, now types of heat loss. What are the types of heat loss? You should know this from previous classes, but we'll go over it again. Convection heat loss means that air is blowing over that baby's body, and so it cools the baby just by the air currents. Conduction is if you would put the baby on a cold scale. They're in contact with a cold surface, and that cold surface makes them cold. Radiation means they're next to, they're not touching a cold surface, but they're close to a cold surface, and it radiates the cool air and the baby gets colder. And then obviously evaporation, baby cools very quickly when they're wet. So you need to definitely know those and how they make the baby cold. Okay, so how do babies generate heat? They generate it by thermogenesis. They have a fast metabolic rate, and it gets faster to try to get them warm. And when they have to increase their metabolic rate, they're going to use more oxygen and glucose. And they cannot shiver, so they use the brown fat as the primary heat source. So if we don't keep them warm by having them skin to skin, having them under a warmer, having them wrapped up nice and warm, they will use up that limited amount of brown fat. Okay, then they start using glucose. So keeping baby warm keeps their blood glucose stable. Letting a baby get cold decreases their blood glucose because they're using the glucose to try to keep themselves warm. Very important concept that you need to know. So whenever you think of a cold baby, you take a temperature on a baby and it's, below 98 and, you get them under a warmer. But what's another thing that you want to check? You want to check their blood glucose because it could be warm. And conversely, if for some reason they have a low blood glucose, they will start to get cold because they don't have that glucose even after they use up their brown fat. If they don't have enough glucose, they're going to get cold. So thermogenesis and glucose consumption are tied together, totally tied together. So when you think of one, you need to be thinking of the other one. Now, a baby will be very flexed when they're cold. Once they are, we get them warm, we get them under a warmer, they will relax a little bit and not be in such tight flexion. But we have to be very, very careful that we don't overheat the baby too. That's why when we have a baby on a warmer, we have a probe that is monitoring their skin temp and then changing the temperature of the warmer so it keeps the baby at a constant heat. So if a baby is under a warmer and their arms are wide out, they assume a posture of extension, and they have flushed skin because they don't have a lot of sweat glands, they can be overheated. So you need to always be sure that you have a probe on when you have a baby under the warmer. And if they do sweat, they'll sweat on their forehead, and then they're for sure they're too warm. Okay, and I have this graphic about thermogenesis. It's figure 23-2 on page 529, and it's just hopefully a way to help you understand. But always know that thermogenesis and blood glucose are totally intertwined and related. Okay, renal adaptations. Almost all babies void in the first 30 hours. We monitor this. If they haven't had a void within 48 hours, we're going to check it out. We usually expect 1 void the first day, 2 voids the second day, all the way up to the 6 days, and then we have 6 to 12 diapers a day. Now, we have to watch baby's fluid load, okay? Usually there's about 40 mils of urine in the bladder at birth. And so a lot of times babies will, as they come through that vaginal squeeze, they will void at birth, and we don't even know it's happening because there's all the other amniotic fluid, etc. So you don't even see it. So that's why we wait 48 hours to investigate that. Babies cannot concentrate their urine, so they have a low glomerular filtration rate. That is so hard for me to say. So they can't concentrate their urine until probably about 3 months. So you have to watch the fluid load. And so when you were in NICU, if a baby was on a drip, they keep very, very close track of how much fluid they are giving them. All right. Now, babies will have uric acid crystals, and this will freak parents out. They look like brick dust, and they're kind of rusty streaks that they'll see in the diaper. And uric acid crystals are very common and normal, but one of the things that you often have to do is really explain that to parents. Okay. All right, let's go on to the tummy. So, gastrointestinal adaptations. Babies can do all of these things, swallow, digest, metabolize, all the things that they can do. They have to learn, though, how to coordinate breathing, sucking, and swallowing reflexes. So that is something that we definitely watch for. And we know that stomach capacity is very small. And you can see day one, it's the size of a cherry. So about a teaspoon. A teaspoon is 5 mils. So that is very small. So day 3, we've gone up quite a bit to 22 to 27 mils. So around not quite an ounce. By the 7 days, then they're getting 45 to 60 mils, so almost 2 ounces, and then 80 to 150 mils is how big their stomach will be by 1 month. And so you need to be sure that you know how we increase the amount of feedings. We're going to increase by 15 to 30 mils per feeding per day when we start increasing the amounts, okay? Let's see, immature cardiac sphincter, you have spit ups, passive spit ups, and it's just because of that cardiac sphincter. We actually used to suction babies' stomachs out quite a bit right after they were born, and they think that that really loosened the esophageal sphincter and has caused a lot of GERD. And so they actually changed that in the neonatal resuscitation program so that we aren't doing that deep suctioning down into the tummy. It's normal for babies to lose 5 to 10% of their birth weight in the first week. We see that quite a bit, especially if they're breastfeeding. They do not have, colostrum is very concentrated. It does not have volume. So, but anything over, we monitor that. Anything over that, we need to be monitoring the baby more closely. Babies are expected to regain their birth weight within a 2-week period, 10 to 14 days. Now, mom's milk is not fully in. She doesn't have volume. She has colostrum, which gives the baby everything they need. It's very rich, liquid gold. But they don't have their milk, the volume of milk, come in till day 3 or 4. And so it can be a little difficult for breastfeeding moms. Those first 3 days can be kind of frustrating if they feel like they're not giving the baby enough. So that's not fun. Anyway, okay, so again with gastrointestinal adaptations, what do stools look like? We have meconium stools, obviously. You've seen that. First 18 to 24 hours. Transitional stool, which is kind of a yellow, seedy, light green. And then, you know, breastfed babies. Breast milk is a natural laxative, so they have looser, more watery stools. Bottle-fed babies will be thicker and pasty and I think smellier. So here you go, meconium, transition, and then bottle baby probably. This is a diaper decoder. It's kind of funny. It talks about stools and abnormal stools. It's kind of funny. So if you want to see that, you can. You don't need to. You just need to know the transition stools and meconium. Okay, we talked about iron storage. Baby uses mom's iron stores. Stops in between 4 to 6 months if mom has been healthy, but oh, excuse me. I apologize. So sorry about that, and it was a spam call anyway, which is really, really frustrating, and sorry if it was really loud for you. Okay, so back to the iron storage. Remember, 4 to 6 months if mom has had healthy nutrition. If not, it's not so. We have to look at iron supplementation more sooner for babies. So we do sometimes in that time period, that 4 to 6 month time period, if we haven't started with iron supplementation, we will see some anemia, and that's normal. Now, bottle-fed babies have iron fortified formula, and so we more often see that anemia in breastfed babies. Carbohydrate metabolism, we want our blood glucose level, well, this says 50 milligrams per deciliter, but we've gone to, I think we're sticking at 40 mils per deciliter. Now it's changed, it's gone down quite a bit. The glucose is lowest at 30 to 90 minutes after birth, and then it starts to rise and stabilize. Obviously, why would it be lowest 30 to 90 minutes after birth? Because it's been using up that glucose to try to get warm right after delivery, start breathing, you know, cardiac adaptations are happening. So there's a lot of metabolism going on and using up that glucose. So let's see. The liver can actually be palpated in the newborn. It takes up about 40% of the abdominal cavity. So when we have mom's iron stores, or when we're feeding iron supplemented formulas to babies, it's not better, because breastfeeding milk has iron stores from the mom that's more bioavailable to the baby. Babies are able to synthesize that iron, the iron stores in breast milk, much more easily. So, and usually blood glucose will stabilize in the first week to 60 to 80 mils per deciliter. So, so what are the most important, because we know hepatic glucose stores are used rapidly during transition. So what do we do as nurses to conserve those stores? What do? We initiate feedings, okay, to increase that glucose, but mostly the first thing we need to do is keep the baby warm so they're not using up what they already have. So skin to skin achieves both of these things, okay? All right, now we're gonna get into bilirubin, yay. All right, so bilirubin, what is bilirubin? It is a breakdown component. When RBCs are destroyed, it's part of the heme, and it has to be bound to plasma albumin. And then it goes to the liver, and it gets conjugated by an enzyme. And it makes it water soluble, and then it gets excreted in the stool or the urine. So if you have bilirubin in and we know babies are going to have higher bilirubin. Why? Because their red blood cells are fetal red blood cells with fetal hemoglobin. There are a lot of them, and they die more quickly. Okay, they get broken down more quickly. So you're going to see more of that. If bilirubin is in its pure form, which means it is unconjugated. Conjugated and unconjugated. Conjugated just means it gets processed. It changes, it gets processed in the liver. Unconjugated means it is in the baby's system. It hasn't been bound to albumin, it hasn't gone through the liver, it hasn't been processed. And so Unconjugated bilirubin is actually potentially toxic. It's not good to have a huge buildup of that bilirubin. And when there's too much of it, unconjugated bilirubin or indirect bilirubin in the body, it starts being stored in the skin, okay? And you see it in mucous membranes, and the babies start looking yellow. When they start looking yellow, they start at their head and it moves down as they have more and more unconjugated bilirubin. Now, it takes a while for that baby to conjugate the bilirubin. Why? Because there's so much more of it because of the fetal red blood cells and the fact that there's more of them, so there's more breakdown. And also the liver is very immature at this point. It hasn't totally developed. So the liver at that point can't keep up with all of the unconjugated bilirubin. So when it does, the unconjugated bilirubin does get into the liver, it gets processed, comes out as conjugated bilirubin. Once it's conjugated, the difference between unconjugated and conjugated is that the conjugated is water soluble. So the liver turned the unconjugated bilirubin into water soluble bilirubin, and it will come out in the stool and the urine. Okay, so that's really important to remember. If the bilirubin has not been processed through the urine, it's going to stay in the system and the baby will start getting yellow. Okay, now this description is called physiologic, that's the blank on the bottom point, physiologic jaundice. Physiologic jaundice. Physiologic, it doesn't have a patho on it, it's physiologic jaundice, is normal newborn jaundice. This is an expected thing that we see, okay? Physiologic jaundice does not start until 24 hours after the baby was born, okay? It goes from head to toe. So those are the differences. Pathologic jaundice, it will start before the baby is 24 hours old. Okay, baby will start getting yellow right away and baby will be very ill. And it's because there is something wrong, probably something wrong with the liver because it is not, it's not working, obviously. And so that is pathologic. Pathologic is sick jaundice. There's something wrong if it's pathologic. So be sure you're very clear on pathologic jaundice versus physiologic jaundice. You need to know what unconjugated and conjugated or indirect and direct bilirubin are and what happens with babies. And this is just a graphic showing you that. Okay. All right, so physiologic jaundice is so normal. We see it in 50% of full-term infants. We see it in 80% of preterm infants. And why would we see that? Because obviously, preterm infants, the liver is going to be even less mature, right? Okay, so these are the signs that it's physiologic or normal jaundice. They start getting yellow after 24 hours. It goes head and downward. Danger lies when there's too much of that unconjugated bilirubin, and it's staining the skin, but it can actually pass the blood-brain barrier and start staining the brain. And then if you have that, you can have cognitive deficits, hearing loss, and blindness. Okay, and that is called kernicterus, when the brain gets stained with bilirubin and it damages the baby's brains. It's called kernicterus. That's a really high bilirubin. When baby has a high unconjugated bilirubin, they will probably become lethargic. So you'll see these signs and they become lethargic and they don't want to eat. And if the liver is processing, but they don't, and conjugating the bilirubin, and they don't have enough, fluid, and they're lethargic and they're not feeding, it's going to be harder to also flush it out. So that can be a problem. Okay. So, and these are just what I've talked about before. Trauma increases hemolysis also. So trauma, what do we talk about when we talk about birth trauma? Usually there is a cephalohematoma. Remember what that is? That's a supply of blood in the scalp because the baby maybe had a vacuum extractor. Any bruising means that there's been trauma and we have increased hemolysis. So that is not good. Interventions, okay, we're checking all of these things. We want to be sure this baby is stooling and peeing. And we're really going to encourage early breastfeeding because we want the baby to have enough fluid to flush it out also, okay? They look at the degree of jaundice. Also, there is actually a chart. It's not just the number of how high the unconjugated bilirubin is or the total bilirubin. It is, what we look at is then what day of life the baby is at. And there's a whole chart that we have in the nursery. And so if the baby has a high bilirubin and they're like in their first 48 hours, we're going to be more worried about that than if they're a week old and they have a high bilirubin, because we know that this whole thing, as the liver matures, it follows a pattern. The liver gets more mature and it gets more efficient and it processes more unconjugated bilirubin. There's less hemolysis, so there's less of it to process also. We know that it's in physiologic jaundice, it's going to arc and then follow a predictable pattern. And so that's why we know that it will go down, and we really watch that chart instead of just looking at the numbers. So we want to encourage breastfeeding early and often, and what we want, because the colostrum doesn't have a lot of volume, we want to be sure we get mom's milk comes in as soon as possible so baby has that fluid volume so they can flush the conjugated bilirubin away. Okay? So it's the degree of jaundice that we're looking at. We have a chart that tells us. And it's more important to follow the rate of rise than to just look at one number. Okay? So besides encouraging early breastfeeding, we're really going to be watching the voids and the stools. And they will, be kind of, they'll be darker and maybe orangey. So what if we're caring for a 2-day-old newborn and the pediatrician says, he calls it breast milk jaundice, but let's say it's physiologic jaundice, okay? And the mother says, oh my gosh, if they have this jaundice, do I have to stop breastfeeding? It sounds like this is coming from my milk. You're going to reply that this is normal, and that we want her to breastfeed more. There's nothing wrong with her milk. And so we're going to encourage early and often breastfeeding. Breastfeeding also, breast milk has, the colostrum especially, has a laxative, and it will help move the stool through more quickly. So that's a good thing too. Okay. Let's see. Hold on one sec. Alrighty. Okay. Immunologic adaptations. What happens with that baby's immune system? It is immature. Baby gets active acquired immunity from mom, okay, in utero, because mom may have an illness or had an immunization, and it kind of bumps up the immune system. And then they get passive acquired immunity through these immunoglobulins. So they get IgG from the placenta. Okay, so that's still kind of an in utero thing, obviously. IgA then comes in the colostrum. That's another really awesome thing about colostrum, besides seeding the gut with normal flora and acting as a laxative. It also gives IgA, so immunoglobulin A. And then IgM isn't usually passively transferred. So that happens in the first 10 to 15 weeks of gestation. So, and yeah, so we watch that. It takes, for IgM, it takes about a year before the baby hits adult levels. So that just is coming on. Let's see. Oh, and IgM is started to be produced by the fetus on its own in 10 to 15 weeks in utero. So let's see. Babies can start producing an immune response to a vaccine within 1 to 2 hours of birth. And so that is really important. What vaccine do we give in the hospital? Hepatitis B. And hepatitis B we're going to give before discharge. We start the series. Babies have the 3 shots just like anything else. Okay. Neuromuscular adaptations. Myelination is incomplete. Myelination. So what does that mean for the nervous system? It means that the CNS is very immature. And what do we see then? We see babies having tremors and kind of be jumpy. The flex position, if a term baby, we would expect the term baby to lie in a flexed position. And that is, if a term baby doesn't have that degree of flexion that we would expect, we would think that there might be something wrong. Babies will have purposeful eye movement right away. Their muscles aren't necessarily strong, and so they may have pseudostrabismus, where they kind of look cross-eyed, but that will go away as their muscles strengthen. A lusty cry is a good adaptation of the nervous system. And then all of the reflexes, and you know newborn reflexes, but there's a table 23-4, pages 541 to 544 that you need to look at. So remember, we do have that really immature nervous system that makes the baby flex, that gives us those primitive reflexes that we usually see. Okay, there's a flexed baby. Okay, behavioral and sensory adaptation. We have habituation and orientation. So habituation means that a newborn processes and responds to auditory and visual stimuli. That is habituation. They get used to and they can ignore the kind of the lights, the sounds. They sort of just can ignore it, and that repetitious disturbing stimuli. So Orientation is the newborn's ability to be alert to, follow, and fixate on visual stimuli. Okay, so they will look at something, and if you move it, they can follow that. They can see contrast, but they don't think they can see colors. And full maturity in the baby, in the infant, doesn't happen until they're about 8 months of age. But newborns can focus on objects 7 to 12 inches away, and that's why it's good to put your face close to the baby. So habituation is the ability to ignore a noisy room. Orientation means they can find and fixate on an object. And if you ever put a newborn under the Christmas tree, they will, on any infant, they'll stare up at those lights and find them fascinating. Hearing is pretty developed, although a newborn may have fluid in their ears. So sometimes it is hard to, they don't hear quite as well because it sounds like they're underwater. And they prefer a female voice because that's what they're used to. Let's see, we talked about vision. Smell, babies recognize mom's smell within 5 days. Taste, they can discern between sweet and sour by 5 days old. And they will use consolability. They use their own resources to actually get them calm themselves. So what do we see with self? So these are self-quieting behaviors. Maybe they're sucking on their hand or their thumb. They basically are comforting themselves. They may suck on their tongue. Okay, when we think about the baby's brain, speech, talking to the baby stimulates development of their left brain, and music actually stimulates the development of their right brain. So, and you can tell babies right away will turn toward a noise or voice that they hear. Let's see. And touch usually will calm a baby, especially if you have warm hands. Okay, so some of the behavioral characteristics, again, they have their response to stimuli, and these are a lot of terms, okay? Temperament, you know, every baby, every person has a different temperament. There's, you know, kind of the easy child, easy baby temperament where they, you know, sleep a lot and they don't, they're not really hyper stimulated and they're pretty relaxed. And then there are some babies who, when they're stimulated, get kind of hyper and really upset. So habituation, when they're getting used to stimulus, and this is a natural protection mechanism because with habituation, it's easy for them to kind of get used to repetitive stimuli, and it helps to prevent them to getting too stimulated, which can cause them to get really upset. Consolability, we already talked about that. Cuddliness, you can see this baby in the picture is very cuddly. This is when they can relax and mold into caregivers' bodies, and babies are famous for that. It's awesome. Now, irritability. Along with temperament, babies can have either a high or low sensory threshold. So they can get very irritable when they get stimulated or overstimulated. And we really see this, an abnormal irritability response, when we take care of babies who are withdrawing from drugs, nicotine, alcohol, and then any other kind of drug too. They don't feel well, and so anything, any noise can really drive them crazy. They have a very low sensory threshold. Crying is their way of communicating, and it's their language. Babies usually develop different cries and different things. You know, some babies do not like to have poopy diapers, and they will be very angry at that. Babies often cry when they are overstimulated. This baby is relaxed. You can see him smile. He looks really happy to be with mama. Okay, some other behavioral characteristics are the states, okay? So baby has a sleep state and a wakeful state, and we kind of assess baby to make sure that they are, you know, when they sleep deeply. If they cry, they can self-calm themselves. You know, do they have a wake state where they're alert? And we'll talk more about those sleep-wake states in just a second in the next slide. So other things that influence their behavior, if they're preterm, their CNS is going to be even more immature and they'll have blunted reactions. And so sometimes if a preterm baby is really stressed out, instead of crying, they will sleep. Or they may have the hiccups, or they may yawn a lot. And that, so they definitely have different responses because of the CNS immaturity. Time since birth, obviously, babies go through a huge transition, or time since the last feeding. If they're really hungry, they're going to get crabbier faster. And then stimuli and their ability to handle the stimuli. Babies tend to be able to sense tension in their environment, especially mom's tension. So it's really important that when mom is feeding the baby, especially, that they are relaxed. And then medication. So you can have baby withdrawal from medication, and it can be like babies can have really tough withdrawals from just anti-anxiety medication. So, and then early on, if mom had a lot of labor meds, babies can be sluggish. Or if they had general anesthesia, babies can be a little more sluggish and not kind of go through the natural patterns that we expect. So these are the sleep-wake states of the baby. And A is baby in a deep sleep, very relaxed, eyes are tightly closed. This baby is asleep, but in a light sleep. Eyes are they maybe move a little more. You may see the eyeballs move underneath the lids, and maybe the eyelids aren't closed all the way. And this baby, the baby is drowsy and they're yawning, and that's a newborn. So that's probably after that first period of reactivity, and they're going into their period of inactivity. And D, the baby is quiet and alert, so they're awake. That baby probably used some self-quieting, sucking on his hand, but still kind of not, wide awake. The wide awake is considered active alert. They're moving around, quiet alert, and when they're in light sleep, best time to start breastfeeding. That active alert too, but the more relaxed the baby is when you put the baby to the breast, I think the more successful that early latches can be. Crying, F is crying, and babies, never a good idea to try to latch a baby on in breastfeeding. When they're crying, you have to calm the baby down first and then try to calm the mama. Okay, this is an awesome slide. I love this one, but it kind of goes through a lot of those characteristics, says it in a different way. So this is a good one to kind of give you just a quick refresher. And that's the end of this lecture. So if you have any questions, you can email me.